speaker today is Dr. Wycliffe Musalia. Dr. Musalia is a gynecologist and gynecologist at Kenyatta National Hospital and at the Medat Gyne-Oncology Center. He has a wide experience, and this is a fairly common malignancy which we do see, and raising awareness about it is going to be beneficial. So I would like to welcome Dr. Musalia to take over and continue with the discussion.
Yeah, thank you so much, Dr. Mokomba, for that kind introduction. As you have said, this is our last in the series of gynecological malignancies that we are looking at. And choriocarcinoma is a fairly common condition in our setting, which we all need to be familiar with. So let me scroll down. It's a bit of hanging of the screen. Just a second. Sorry for that hitch. Let me just try and share again. I see this. Sorry again. Don't know why I can't just move my slide. I'll try again and see. Sorry about that. I don't know why my screen is just not moving at all. Yeah. Okay. Let me try and change my internet source. Okay. And use.
You have sent them.
Yeah, I had sent her. Just a second.
Agnes, you can run the slides from your end.
Hello, Agnes. Hello.
Yes, Dr.
Yeah, I was trying to move my slides, but I don't know, it looks like my internet is pretty low. I don't know, I had shared them with you. Can someone assist? Just scroll on the slides for me. I could stop sharing. Hello?
Okay, I've determined that we download for you.
Let me log out and log in again, I see. Sorry for that hitch. Hmm? It's here. Sorry. Hello?
Yeah, you are in. Continue.
You know.
Yeah, I think now we are able to move on. Sorry for all that inconvenience. As I said, my internet speeds were a bit down. So as I said, we are going to look at choriocarcinoma. And in our outline, back again to the same problem. I can't just move my slides.
Use the computer arrows, the up and down.
Yeah, that's what I'm using, Daktari. It's just unfortunate that this thing is letting me down.
So go to desktop.
Just a second.
Okay. Your internet is unstable.
Yeah.
Your slides are on. So play this. No, this is down there.
Yes, sir. Do you have your laptop here?
No, no. This
This is,
Okay, log on to the internet. Because they're ready for it. It's because there are two gadgets.
What has happened again? Hello? Sorry, I think this is crazy. Okay, so
Hello, the team from the office, kindly run the slides for him. Yeah, send them on mail.
Apologies for those.
okay.
Yes, please. You're putting that up. Thank you.
Are we together now? Sorry. Yeah, so I think now we are good. We'll restart again. And as I said, I apologize for all this confusion. So we look at the introduction where we will cover the case definition for choriocarcinoma and a little bit of epidemiology. Then we look at the pathology of this condition, how a patient with the choriocarcinoma will present to us. Then how do we make a diagnosis of the condition of choriocarcinoma and the case management. And they will briefly look at outcomes using our KNH experience. Then lastly, we'll end with the question and answer session. So in terms of a definition, choriocarcinoma is basically a malignancy of the trophoblast. And we all know when we are talking about the trophoblast, we are talking in reference to the epithelium of the placenta. So this is basically a malignancy of a chorionic epithelium. It is one of the more serious conditions, but it belongs to a spectra of conditions we refer to as the GTDs when they are malignant as GTNs. So, yeah, so in terms of a definition, case definition for choriocarcinoma, basically, choriocarcinoma is a histologic diagnosis, which is often not available most of the time. And in terms of case management, we do not require a histological diagnosis for us to manage these patients. So more commonly, the term used in the clinical setting is a GTN, which is sort of a group terminology referring to all the neoplastic forms of GTD. Choriocarcinoma, therefore, is classified as a high-risk GTD, but we do know the other, forms of GTNs, which could be falling in the low-risk category. In terms of epidemiology, choriocarcinoma tends to form like 2 to 5% of all the cases of GTDs. So it is not all that common. And it tends to occur in around 1 in 20,000 pregnancies. 3 to 5% of all the patients with molar pregnancy will develop choriocarcinoma. Of course, this depends on where you are and how you are collecting your data. Some people can give a higher figure of around 10, some even 15%. Women with a history of molar pregnancy tend to have a higher risk of developing choriocarcinoma. And this is more so if they have, say, a second occurrence of a molar pregnancy event. However, generally, what we find is that following molar pregnancy, in terms of the origin of choriocarcinoma, many of them tend to occur after a mole, but around 25% will occur after term pregnancy, and a few will occur after an abortion or an ectopic pregnancy. These statistics again depend on where you're collecting your data. Some centers record more choriocarcinomas after term pregnancy. So what are some of the risk factors that lead to the development of choriocarcinoma? And generally, when we are looking at this, you'll find, again, these are the same risk factors that would lead to, say, molar pregnancy and GTDs in general. So extremes of reproductive age, if one has a history of prior molar pregnancy, if the client you're dealing with, sometimes we find those of low socioeconomic status, and here things to do with nutrition coming, blood groups, and as we've seen earlier, history of previous mole is a risk factor. Other risk factors would include the chromosome anomalies, aneuploidy and polyploidy. We also have medical complications, which these ones tend to just sort of increase the risk of one developing molar pregnancy, choriocarcinoma when you have a molar pregnancy. In terms of geography, you find that certain regions of the globe tend to have more GTDs as compared to others. Women who have had at least one of these risk factors have a chance of developing postmolar GTN with a 4% risk in those with no risk factors. So like if you have a complete mole, which tends to have, say, higher beta HCGs and the other associated risk factors, then you have a higher chance of developing choriocarcinoma. What is the pathophysiology when it comes to developing these chorionic malignancies? The exact pathophysiology is not understood, but like all cancers, you'll find that there could be mutations and overexpressions of certain tumor suppressor genes like P53 mutation. They will be overexpressed in these cells of patients who have choriocarcinoma. So generally, it is a mutation at the cellular level, which leads to either proliferation of tumor cells with the downgrading of apoptosis. I think that is more of the same, downregulation of apoptosis. And so globally, what we find is that the Orientals tend to have more of this disease as opposed to people in the western part of the globe. Africa tends to fall in between. In Kenya here, GTN constitutes about 2% of all the reproductive tract cancers. And because they occur in the reproductive age, like in KNH, our mean age is around 35. And generally, you would not say that this disease tends to occur more in women who are HIV positive. It's just sort of even. So what do we find? Although choriocarcinoma is a highly chemosensitive tumor, that's one of the things we'll find. But locally, we still tend to experience a lot of morbidity and mortality because of the lack of specialized treatment centers, trained personnel, and delays in diagnosis and referral. So this is basically going to be the gist of our conversation today. So I think that aspect of pathology, where we have seen that choriocarcinoma is an epithelial tumor of the trophoblast. It may arise from the uterus, but can also arise from the ovary or the tube in cases of ectopic pregnancy. So when you look at slides of patients who have choriocarcinoma, what you see is sheets of trophoblastic cellular proliferation with areas of necrosis and hemorrhage, and the villi pattern formation is absent. So just some of the slides. I will not dwell so much into that, but you can also do immunos where the diagnosis is in doubt and you stain for HCG, and that is what you'll see when you do immunohistochemistry. So these are just some of the pictures you'll see. The other entities which might resemble choriocarcinoma like placentocyte trophoblastic tumor and ETT, but this will be reported by the pathologist. These are just some of the pictures. So once a patient has a choriocarcinoma, which we have seen could arise from the uterus, it may arise from the tube or the ovary, what happens is there is spread of the disease, and the spread can be either local to the surrounding structures or commonly hematogenous through the venous system. The local spread will be to the adjacent reproductive structures where you find the uterus, myometrium, infiltration, vagina, parametrial structures, ovaries. And then distant spread, which is usually hematogenous, will quickly go to the lungs, anterior vaginal wall, brain, and the liver mets. So how do patients who have choriocarcinoma present to us? The presentation usually is dependent on the symptoms associated to local growth and the distant spread. So some of these patients will come to us and tell us they had a molar pregnancy, but however, that history of molar pregnancy may not be there. Many times, especially if the pregnancy event was an ectopic or an abortion or a term pregnancy, we tend to miss, because what they come to us with is a irregular vaginal bleeding, and many times we associate it either with an incomplete evacuation or just an abnormal uterine bleeding. So if the history of molar pregnancy is not very evident, then we easily miss the diagnosis. They could also come to us just with the general ill health. And if there is a metastasis to the lungs, then they can come to us with a cough. Sometimes we have seen even them coming with the convulsions, sometimes epigastric pain, or brisk vaginal bleeding. So when you examine these patients, what do you find? You'll find them sick looking, they may be pale, and you will find systemically, they may not have enlarged nodes as such, okay? So the main findings would be in the abdomen, where they could have an enlarged uterus. Sometimes it is not that markedly enlarged. Sometimes they have bilateral ovarian masses, and many of them have been referred to us as cases of possible ovarian malignancy. If you do a speculum exam, sometimes you are lucky to find a nodule on the anterior vaginal wall, which is suspicious. We'll see some of these pictures. And they, depending on how long the disease has been going on, they could be wasted. So once you have this sort of clinical presentation, then you've got to try and figure out what could be going on. And this is where we have the elephant in the room, because many times these patients will be investigated for abnormal vaginal bleeding. But for you to be able to establish a diagnosis, one key guide is to always use an HCG titer. So if a patient presents to us, we need to make serious consideration for doing a beta HCG. And this can either be detected in serum or urine. Mostly we do serum beta HCG. For urine, you'll be doing a pregnancy test. So, however, sometimes we have cases which come to us during our follow-up of patients who have molar pregnancy, and we've done suction evacuation. And in these particular cases, we have a specific criteria for making a diagnosis of GTN. You'll see, because many times we do not have a histological diagnosis of choriocarcinoma, we tend to just discuss the two hand in hand. You're either looking at GTN, or if in the event you have the histological diagnosis, then you'll say you're looking at choriocarcinoma. So you'll see in this conversation, some of the things we are looking at are in relation to GTN. So probably maybe if you did a suction evacuation and you submitted your specimens for pathology, you may get a histologic diagnosis and it will be specific. It could tell you what your patient has is choriocarcinoma or invasive mole. Sometimes patients who come to us postpartum or later on after delivery remote, and they just have abnormal uterine bleeding, you may do a DNC, and your histology can come back telling you that what your patient has is either choriocarcinoma, PSST, or ETT. So, however, in the setting of a post-molar pregnancy follow-up, if your beta-HCGs remain elevated or they become positive after they've gone to a negative, or they are plateauing, or you find sometimes you've done your evacuation, you've done a good job, and you expect your titers to regress, but maybe like 4 weeks post-evacuation, you still have high beta-HCG titers, like over 20,000. Then that one is suspicious that you could be dealing with GTN. If your beta-HCG levels remain positive after 15 weeks, I think these 15 weeks, different institutions have different cutoffs. At KNH here, we use a cutoff of 8 weeks. That if you have persistently high levels of beta-HCG, 8 weeks post-suction evacuation, then we will label you as having possible GTN. However, in all these cases where you have elevations of beta-HCG, then we have to rule out the possibility of a pregnancy. So how do we make a diagnosis if in the event what we had was not a molar pregnancy and the patient has presented to us with certain symptoms? They are usually non-specific, sometimes maybe with abnormal vaginal bleeding. So here, as I said earlier, often the diagnosis is delayed and it requires a high index of suspicion. So the clinician should assess the clinical symptoms and signs that you find on your examination, and consider choriocarcinoma as a differential. More often, what I find is important is for you to just do a PDT in any woman of reproductive age who presents to the OPD, because a urine PDT is like a screening test. So if it comes back positive, then it arouses your sense of suspicion and you may be forced to do a quantitative serum beta-HCG. And if it's elevated, then your query for a pregnancy event or a GTN or possibly a non-gestational choriocarcinoma will come into the picture. So a basic urine PDT done in any of our OPDs is the best strategy for possibly early diagnosis of GTNs and the choriocarcinoma when patients present to us. So what will be in your differential diagnosis once you have a positive PDT? As we know, it could be a pregnancy, it may be an incomplete, whatever, all those pregnancy-related events. But in terms of malignancy, you could be looking at a placentocyte trophoblastic tumor or a seminoma, which is a non-gestational choriocarcinoma, a mixed germ cell tumor, or a solid variant of the yolk sac tumor. These germ cell tumors tend to also produce a beta-HCG. So this will be in your differential. But of course, if you are looking at GTN or choriocarcinoma, then that will be your primary diagnosis. So once you have that, then we expect you, based on your beta-HCG titers and your clinical assessment, you should be able to say, I'm considering that this patient has a GTN or choriocarcinoma. So the other workups that we tend to do after this, of course, sometimes they build up into your clinical picture. Say you do an abdominal pelvic ultrasound scan and it shows certain myometrial masses or maybe intrauterine masses or bilateral ovarian cysts. This will build into your clinical picture, and it could also help you in terms of staging, because you may find the disease has spread maybe in the liver, there are liver masses, there are splenic masses, or you do a chest X-ray and you see cannonballs. Sometimes you don't have this clear-cut thing, and what you just have is what you thought is abnormal uterine bleeding as your diagnosis of consideration. And at that particular time, you may plan to do a DNC. And when you do a DNC, you'll submit your specimens for pathology. But you'll find, as I said earlier, if you had done probably a urine PDT, even as you're doing to do a DNC, you'll be asking yourself, am I doing a DNC for an incomplete abortion, or why am I doing a DNC in a patient who has a positive urine pregnancy test? So that is a basic test, which I believe if we applied it across board, we shouldn't have a major issue when it comes to diagnosing a choriocarcinoma. So suffice to say here, when you're doing a DNC in the setting of choriocarcinoma, there's significant risk of uterine perforation. And that's why normally we do not advocate for you to do PDT. I mean, DNC. We just say use your clinical signs plus your history and your beta HCG, and you may be in a position to make a diagnosis. I think that point CSF is more of anecdotal, but usually if you suspect that your patient has a choriocarcinoma, we will do other metastatic workup that will include probably a CT scan of the brain, and sometimes a CT scan of the chest. Sorry. So with all this workup, then you're in a position to stage your patient, and the stages are there from 1 to 4. I will not go through all that. What we also tend to do is to classify our disease, and there are many approaches to it. Sometimes some people may classify it as non-metastatic disease or metastatic disease, which carries a poor prognosis, because once the disease has spread out, especially to the liver and the brain, then the outlook tends to be a little poor. So even with this initial clinical assessment, you can tend to sort of place your patient as either a good prognostic patient or a poor prognosis, where disease is confined to the uterus, where you have very low serum beta HCGs, and where the patient has presented to us early after the antecedent pregnancy event, and we have not exposed this patient to any previous chemotherapy. So these tend to be favorable factors, and we'll see all these have been aggregated into the WHO scoring list. So again, an item there on a poor prognosis, like you find a patient comes to you 1 year after a delivery with what you suspect to be choriocarcinoma, then that patient will definitely be a poor prognosis. If your serum beta HCG at the time you're seeing the patient is over 100,000, this is a high burden of disease just based on the HCG levels, because these are closely related to the cellular volume in the body. Patients who have mets to the brain, or patients who have been exposed to previous chemotherapy. GTN after term pregnancy, we tend to say this is either a choriocarcinoma or a PSST. So if you have GTN after term pregnancy, then this is a poor prognostic indicator. So these are just some pictures of what you may see when you're evaluating this patient. Like this is a lesion you may find when you do your speculum exam in a patient who has abnormal vaginal bleeding. And when you see that, sometimes there's the temptation to take a biopsy. And we've seen this once in a while. And when the biopsy is taken, now you have torrential bleeding from the anterior vaginal wall, which sometimes you are unable to arrest. And as I said, again, this can easily be avoided if you have done a pregnancy test, because if you have done a pregnancy test and it's positive, and you're doing your speculum exam and you see this, then we be cautious before you take a biopsy. Many times we do not recommend that you take a biopsy. Sometimes in your workup, you do a chest X-ray, and this is what you might see, cannonballs all over. And so lesions all over. So this is suggestive of chest mets. Patient might come in convulsing. Recently, we had a patient from Maragua who had gone to Maragua, Muranga, treated for what they thought was DUB, a young girl of around 20 years. And eventually she convulsed. And when the CT scan was done, they thought it's an SOL. Until she was referred to Kenyatta, and now it's when at some point now beta HCG is requested for, and you find it's very high. And so the diagnosis changes from what they were initially thinking is a brain abscess to GTN. So that's why I'm saying just doing a urine PDT as a caregiver, it will raise your index of suspicion for GTN very high, and even choriocarcinoma. So this is the WHO scoring system, which we use when we want to initiate treatment. It helps us to place the patient, whether this patient will require multi-drug therapy, combination therapy, or just single drug regimen. Patients who are scored low, we just put on a single drug regimen, but those who score high, then we will put on multiple drug regimen. So as you can see down there, we are saying if you score less than 5, we say you're low risk. If you score more than 7, then you're high risk. 5 to 7 is in between. At KNH, what we do at the moment, we all put them on EMACO, which is the regimen for high-risk disease or choriocarcinoma. So some of the factors we look at is age, prior pregnancy, whether it was a term pregnancy, you can see that scoring high. Most tend to score just 0. The interval, the longer you stay, the more you give these mutant cells time to grow in the body and spread around, and therefore you will present with more advanced disease. Pre-treatment beta HCG correlating with the volume of disease, okay? Here I think what I need to caution is that if say you see a patient who has a mole, although they may have high beta HCG, say 100,000, what this means is that when you're doing follow-up, this patient may have a higher chance of persistent disease or GTN, but does not mean at that particular point, if they have high beta HCGs, before your suction evacuation, they have a GTN. No, you just treat them the usual way, and then you do follow-up. Tumor sizes, again, you can see there relating with the tumor burden. Mets to the brain and liver, carrying a poorer outcome and higher score. Number of meds. So this is basically just to assess the disease burden. Then exposure to chemo tends to, if say you have not responded to a single agent, then it means your cells have mutated and they are probably chemo resistant. You may now not respond very well to second line. So the definitive treatment of choriocarcinoma should be preferably be done in what we call a GTN center and or a gynaecology unit. The reason why this is coming up is because what you find is that these patients have special needs. And as you'll see, in spite of what you do, lumped together with the other patients, they tend to fare poorly because they need, mostly they need a lot of transfusion. And what we tend to find is that because there are other competing needs, maybe a patient with an ectopic or a patient who has a PPH, you'll find the patient with PPH will be given preference, or the patient with ectopic, and these ones miss out. And even in KNH, you'll see when we look at our outcomes, we tend to lose a lot of them because of delayed transfusion. Treatment depends on the score and the presence of metastasis. So if your score is high, we'll put you on multiple regimen, drug regimen. If your score is low, then single agent. So main treatment here is chemotherapy. Surgery has a limited role. So this is also important because many times you'll find people rushing because the patient is sort of bleeding to take to theater, but you need to sort of assess well and see whether really theater would be the optimal approach. So for low-risk disease, single agent we use is either methotrexate or actinomycin. Actinomycin has gained preference. It can be used as an outpatient basis. Sometimes you have several regimens of this where the patient can be admitted and given as an inpatient. But again, you will look at your beta HCGs and decide whether you want to do it as a day case in outpatient or inpatient. And when we use methotrexate, we add on folinic to prevent the adverse side effects, mostly bone marrow suppression and mucositis. So patients who have a high-risk disease or high scores of more than 7, then we use combination therapy. And as we said, choriocarcinoma, once that is your diagnosis, then you will use multiple drug regimen. And here, in our setting, mostly we use Emaco, which is a topocyte, methotrexate, and actinomycin D, cyclophosphamide, and vincristine. These regimens are there. I'll not go into the details of the dosing. So prior to chemo, we do, of course, a pre-chemo prep, which includes a blood count, renal function, and kidney function. You must have your baseline beta-HCGs because this is what you'll be using as a tool for monitoring response. We put them on antiemetics and we hydrate them. And these cycles are normally given 2 to 3 weekly intervals, usually preferably every 15th day. And if you prolong the interval, then many times you'll find you're now having suboptimal response. The only time we delay the next cycle is because of maybe a patient has developed an adverse reaction, usually a neutropenia or a low HB. So we'll do like that until we get a negative, and thereafter we give the 3 consolidative cycles to mop up any remnant cells. So how do we assess? I mean, in terms of response to chemotherapy, this must be assessed, and usually the beta-HCG level plus the resolution of clinical symptoms. Mostly you'll find, even though the patient was bleeding, after your first or second cycle, the bleeding has stopped. So that is a good indicator. And of course, if they had the meds to the brain, you'll find the improvement in the GCS. On average at KNH, usually by 5th cycle for low risk, we are turning to negative. We found that from experience, for you to get to a negative for high risk disease, we tend to do around 8 cycles. There are some factors which we have found may be associated with the poor response. And usually here, we are dealing with patients who have delayed diagnosis. We have had cases where patients who have had up to even 8, 7 MVS in our OPDs because they were being treated for incomplete abortion. Because every time they are evacuated, they go home, they come back after 2-3 weeks, they are still bleeding. You do an ultrasound, pregnancy test is positive, and the ultrasound will show retained products. So this is where we need to be sensitive that if you have evacuated a patient for an abortion, twice is good enough. But by the 3rd time, ask yourself why we are not having complete evacuation. And probably what you're dealing with is choriocarcinoma or a GTN. So sometimes patients have very low HBs, they will not do well. So if you have failed first line, in which case your beta-HCGs are not coming down, or they are starting to go up, or you have persistent bleeding in spite of giving maybe a few cycles of chemo, then you have to reevaluate your patient and make consideration for 2nd line therapy. And this is where, again, these patients need to be in a good center where we review their progress as a team and make a decision for what to do if there is poor response. Commonly, we can use what we call MIAP or the other regimens that are there which can be used to give to patients who have failed to respond to the first line therapy. Usually, if patients who are on a single agent, we'll convert them to multiple drug regimen. If they're on multiple drug regimen, then we play around with the combinations. So what is the role of surgery when it comes to the management of GTN and choriocarcinoma? Basically, surgery has a limited role, as I said, but doesn't mean that you can't do surgery. If a patient has intractable hemorrhage, and sometimes a hysterectomy is done as a life-saving procedure. So you find your source of bleeding is from the uterus, and it's so heavy, you have done what you can, but the patient is still bleeding and you don't have an alternative. Then a hysterectomy can be life-saving. Sometimes patients come to us and maybe the only focus of the disease is within the uterine cavity. We've done the metastatic workup. There's no chest disease. There's no disease outside the uterus. Then you can do a hysterectomy. But still, even when we do a hysterectomy in that setting, we will not tell the patient this is enough. Patient will still require to be put on chemo. We have had cases where maybe in the peripheries, sorry to use that term, but say in the level 4 facilities, someone might say, okay, this patient has a mole, or what sometimes they even have actually GTN, but you're thinking is a mole. And you just go and do a hysterectomy, and the patient goes home. And you'll find now the disease you have not eliminated, because the disease is still there, microscopic, maybe in the pelvis or even in the chest. And you'll find now the patient presenting months later with very advanced disease, because they were told after the hysterectomy this was sufficient, but that is not the case. So sometimes we have patients who probably have what we may suspect to be a placentocide trophoblastic tumor, which is not responding to chemo, but it's just localized, maybe a portion. So in that particular case, you could also consider surgery. In some cases, when the hysterectomy is done, you'll find now there is a resolution of the symptoms, and the beta GCG now turns negative. Sometimes you may have a disease in other sides, maybe in the chest or in the liver, and just not responding to chemo. And one may give consideration to doing surgery. But of course here, again, to require a disciplinary approach, because there are other options like radiation. So yeah, as we conclude, there's role for radiation in patients who have choriocarcinoma. And these are usually patients with high risk disease, sometimes best to the liver or the brain. And whether you're going to use radiation as first line or second line depends on the clinical scenario. The patient we had, let's say like from Ranga, came into us and now was having signs of raised intracranial pressure because of a bleed in the brain. And the conversation was whether to give radiation or do neurosurgery to evacuate the bleed. But after conversation, now you find like in that case, we decided to give this patient radiation, and the response was dramatic. You realize like surgery in a patient who has a choriocarcinoma, these tumors are usually highly vascular. So even when you go to the brain to do surgery, you may not achieve hemostasis. So you need to discuss as a team and agree on the best approach. So maybe these are just slides to show you like in KNH what we are doing mostly. In a majority of our patients, up to 75%, we are using chemo, and the surgery only in around 5%. Chemo radiation also very low. So it just tells you that chemotherapy is the mainstay treatment for choriocarcinoma. So what are the outcomes? If the disease is low risk, meaning is just another form of GTN, not necessarily choriocarcinoma, the cure rate is usually very good, almost approaching 100%. But for high risk disease, high score disease, sometimes we lose some of these patients, and our outcomes range between 75 to 85%. Even when we use all these modalities of treatment, sometimes you lose a patient. And we'll see like now, Kumba in his study that is yet to be published. And this is what we need, because sometimes when you just give these patients medicines, we don't know what is happening to them. So you find like in this particular study, study sample of 64, we had a good response. These are high risk GTN patients. 43 responded, 24 required a change in regimen, 6 were lost to follow up, and 21, that is almost 33%, died. When you look at the statistics, some of these patients were dying much later after even the beta HCG had turned negative, and that is quite intriguing. So what were some of the causes of death in these patients who have a high-risk GTN, which Dr. Kumba looked at? A good number of them died because of hemorrhage, okay? One patient died because of sepsis. So you can see majority of our patients who have a high-risk GTN die because of hemorrhage. And this is why I say we need a specialized GTN center where now these patients are able to receive adequate care, at least separate from the other competing needs which you'll find in our units when you're looking at a normal gynae unit. There's PPH, there's ectopic, there's whoever, patients always requiring blood. We also tend to lose some of them, like here we lost 2 because of pulmonary embolism. We lost 1 because of chemotoxicity, and 1 had chest meds, and they were bleeding, coughing blood, and even when the scores were quite high, and we even tried the slow induction therapy, they were not responding. So again, saying that early diagnosis is sometimes the only way to avert some of these things. 1 died of liver failure. So I think that is a repeat of the same, so I'll not go through that. So after treatment, what do we do? When we have 3 negative titers of beta HCG, we usually give, once we get to negative, we usually give 3 cycles of consolidation chemo, and then thereafter, we do follow-up. And during follow-up, we prefer these patients to be on contraception so that they do not conceive. Otherwise, then you will not be able to interpret your rising beta HCG titers. So you need to talk to them and give them information so that they are able to comply. And oral contraceptives, combined pills are what we prefer. We avoid the others because sometimes we get irregular bleeding, which we are unable to interpret. Remember, in the setting of choriocarcinoma and GTN, if a patient has any abnormal vaginal bleeding, your first query is there disease recurrence? And so that is why we want them to have regular menstrual flow. In the next pregnancy, if they're able to complete the period of follow-up, we would like to do an early first trimester scan so that we can rule out the possibility of a mole again, because we say if you have had a previous mole, there's a chance that you can also develop one in the subsequent pregnancy. So if you do an early scan, then you're able to pick it and intervene appropriately. For low-risk disease, usually we follow them up for a year, and thereafter we discharge them to the regular gynae follow-up. For high-risk disease, we do 2 years. During follow-up, it is important to do pelvic examination plus chest x-rays to see. But the most important thing during follow-up is doing a beta HCG, which will detect any disease at a very early stage. As I said, we need more studies to look at the long-term outcomes in these patients, including their survival long-term. We realize, as I said, some of them tend to die much later after we have even turned negative. And we need to look at the reasons why we lose some of those. So in conclusion, choriocarcinoma is a condition which requires a high index of suspicion. And my suggestion is that we should introduce a routine PDT in every woman who is seen in our OPD, as long as they are of reproductive age. Or even postmenopausal women, they can be done a PDT because it tends to shape your thinking significantly. This happens even in the UK. They already have this protocol for making sure that everybody who is seen in OPD, as long as you're a woman, you'll be done a PDT so that they're able to pick cases of GTN quite early. Early referral on suspicion is important, and we need multidisciplinary teams, because you realize for choriocarcinoma, if we are going to salvage these women who are dying, it is not a one-man show. It is a team approach. We need the radio-oncologists on board. We need blood transfusion service. We need neurosurgeons, sometimes cardiothoracic surgeons, because you could be having lesions in the. So that is the end of our presentation. And sorry for the initial hitch. This is quite unfortunate. I've never had this sort of thing. But
thank you, Dr.
things happen. So I will, stop slide sharing and invite comments from the audience. Thank you, Dr. Mokomba, and back to you again.
Yeah, thank you, Dr. Musalia, for that impressive presentation. I think it has enlightened those who are in the audience to improve their skills in picking up gestational trophoblastic neoplasia patients and make sure they access the best treatment. If anybody has comments, they can raise their hand, then I'll give them a chance. Otherwise, we can go to the Q&A so those who want to make a comment, you have a chance also. So the question one on an anonymous attendee, people should aspire to be known. Please expand on the role of surgery. I think he has done that very well. Dr. Musali.
Yeah, I think we said if the patient is bleeding profusely, if it's from the uterus, and you have no other option, then there is the role of doing a hysterectomy as a life-saving procedure. But we say the doing of a hysterectomy does not in itself mean that you have cured the disease. The patient will still have to go through chemotherapy. Other signs of bleeding, you need to discuss, because we said if say there's bleeding in the brain, you may have to really ask yourself whether you're going to do surgery in that particular case. So surgery has a role, but you need to make good clinical judgment.
Yeah, somebody is asking, is there any role for induction of labor in evacuation of HMOL, I guess, instead of doing the suction evacuation?
No, if you use and this is a very important point, because I think with the availability of misoprostol and other inducing agents, many people are tempted to try and induce labor in patients who have moles. You realize when the woman starts to contract, you'll get torrential hemorrhage. So usually the best approach is to do the suction evacuation. You will do a gentle dilatation of the cervix when you are in theater. But if you give misoprostol, sometimes your patient will start bleeding on the bed and you're not ready to do the evacuation. Maybe where we can have some limited role is patients who have partial moles, where sometimes the cervix is not very ripe. And usually partial moles present with the very small for gestational age uteruses. And you can actually ripen the cervix with the misoprostol before you go to do suction evacuation. So for, yeah?
Yeah, I think that is clear.
Yeah.
So it's suction evacuation. The induction in the ward is not recommended because you can have profuse bleeding and actually you lose the patient within a few minutes. Next, what's best management for a patient with GTD at 42 weeks? I think they are managed the same way. With HMOL, suction evacuation in theater. With GTN, you do scoring in a similar manner. Somebody is asking Ayumba, what if the WHO's prognostic score is low risk, but there is no histology? Dr. Musari.
Yeah, if the WHO is quite sensitive because it tells us the burden of disease. And what we have agreed is that if your burden of disease is down, meaning a low score, then that patient will do very well with single agent. You do not need to have histology for you to start your patient on a single agent treatment. So just the high beta HCG, the clinical scenario, and your scoring will allow you to decide which regimen to use.
Yeah, to add on to that, it is among the few conditions where you actually, most of the patients are treated just with the levels of beta HCG. It is not mandatory to have histology because if you try to take biopsies, say of vaginal mets or liver mets or lung mets, you can cause a lot of bleeding. So long as you have serial elevation of the beta HCG hormone levels and that history of a pregnancy or a miscarriage, then you are allowed to treat without going for histology. Okay.
I don't know, that patient where somebody was asking, she came at 42 weeks. I'm not sure what they meant, whether it's 42 weeks gestation or what exactly they had. But if there's a coexisting pregnancy at 42 weeks, have you delivered? Okay, how did you make the diagnosis of GTD? Or you're saying there's a uterine size of almost 42 weeks. So that needs clarification. But if the uterus is very huge, then that is where you know you might bleed more and you need to prepare well for transfusion. And basically, also in case the bleeding is going to be a lot, then you will have to use all your maneuvers to control bleeding in a very bulky uterus. So this will need to be discussed, but I'm not so sure whether that is exactly what they were asking.
Okay, I think the last question, for a patient post-chemotherapy for GTN, what long-term complications do these patients face after they finish the treatment for GTN?
Most of them, as anyone else, will be cancer survivors. So of course, there are the psychological issues of having had this sort of condition, but they tend to do well. They could have other issues related to maybe fertility, because we are using chemo, but that again will depend on their age and the reproductive reserve. But majority of them, because they are usually young, they tend to do well and they do not develop major issues. So I think that is what I'll say for that. But as I said that, it is important that these patients are sort of followed up closely, because some of them have been known to develop some complications, including like DVT. There's a patient we had who we treated well, got negative titers, went home, but because of the prolonged hospital stay, while at home, she developed an emboli and died. So it's just good to have them on follow-up. Yeah.
Okay, thank you, Dr. Musalia. If there's anybody who wants to make a comment before we conclude, because of time, we've ran beyond time. Anybody with a burning comment from the audience? Well, I don't, I'm not getting any. I think most of the questions basically are dealing with what we have said. I would, at this point, want to end the webinar. Thank you very much for listening to us. Thank you very much. I think today we end it there. Asante.
Thank you so much, Dr. Mokamba, for the presentation. Wish the audience well.
I think this room is, one doesn't hear outside there.
One doesn't. Ukiwa hapa ukiuliza maswali watu wanasikiza.